Good evening, everyone, and welcome to our community conversation on healthcare. We're excited to share some of the opportunities that have happened in healthcare in this community and throughout the province. My name is Nancy McConnell-Maxner. I work with Nova Scotia Health, and I will be moderating the session tonight. I trust that you had an opportunity to go around the back of the tables and see and get some information from our partners at the back. Lots of really good information there. If you didn't get a chance on the way in, they will be here on the way out to ask questions as well. And just to kind of give you an overview for the evening, we'll do a welcome and some introductions. We'll have some opening notes from our panel, and then it is up to you guys. So it is a question and answer format. I have some pre-submitted questions here from people that either submitted ahead of time because they weren't going to be here or because they didn't want to read them themselves. And so I can read some of those. If you have questions and you got one of these little cards and you want me to read your question for you, you can just send it in and we'll read it. But we will have mics to go around so that you can answer the question, ask the question yourselves to the panel. I also wanted to just mention that this portion of the evening will be recorded. For those that were not able to join us tonight, or if you just want to go back and rewatch it yourselves, it will be on the same site that you signed up for. So with that, I'm actually going to now pass it over to the Honourable Alan McMaster, the Minister of Finance and Treasury Board, and the MLA for Inverness, for official welcome.
Thank you very much. It's nice to see a big turnout here in Port Hawkesbury tonight. We were in Inverness earlier today, and I want to acknowledge we have a couple of councillors in Port Hawkesbury, Huey McDougall and Mark McIver. I see them sitting there, and I was scanning the room. I don't think there's any others at the moment here, but and MLA Trevor Boudreau, who is no stranger to Port Hawkesbury and is not too far away in Richmond. So welcome, Trevor. Michelle Thompson has roots in Middle River. She's been a nurse for 30 years now, and she represents Antigonish in the legislature. A great background to have as a health minister. She's been there, she's seen it all. So welcome, Minister Thompson. We have Karen Oldfield, who's the CEO of the Nova Scotia Health Authority, and we have the Deputy Minister of Health, Jeannine Lagassé, who's with us as well tonight. So, and there are also at the back of the room, you may have met some of them, a welcome to all the visiting health staff who are here tonight. It is great to see them on the ground. They're here to hear your thoughts, and I think it's important for people to get out into communities and listen, and that's what tonight is about. So I could say some more, but this night is about what you have to say. So I'm going to cut my remarks short, and I'm going to let you continue. Have a good evening, folks, and I hope you get something good out of tonight's proceedings.
Thanks, Alan. Good evening, everyone. Good evening, everyone. My name is Michelle Thompson. As Minister McMaster said, I'm the MLA for Antigonish. I am the Minister of Health. I'm a graduate of CEREC. I graduated a while ago. I graduated in 1990 from CEREC. I came up for a year to finish my grade 12 year, so it's a little bit familiar to me. So I'll just give a bit of a recap. We certainly ran a platform to fix healthcare. It resonated with Nova Scotians during the last election. And when we formed government, we made some quick and bold steps to address the healthcare system and put it back on its feet. So one of the things that we did, we have a new health leadership team. So prior to this current model, Nova Scotia Health and Department of Health and Wellness ran parallel, to be generous. They didn't have a lot of opportunity or didn't seize the opportunity in the past to work together. But now we have a health leadership team that is well represented by Department of Health and Nova Scotia Health. So policy and funder now works with the operator, and every week they sit together as a team and they make decisions for the system, which before we often hear the word silos, and that's what that meant. That these folks were running parallel and didn't often know what the other one was doing. And so it was really important that we have a health leadership team that's experienced and agile and is able to address situations as they come up in a timely fashion. And so we've had that for the last 15 months, and it's enabled us to do some things in a very quick fashion. We also went around and talked to healthcare workers. We started in Neils Harbor and went all the way to Yarmouth, and we talked to a lot of healthcare workers about what were they experiencing. We wanted to affirm what we had said in the platform, that it resonated with healthcare workers, that we heard directly from them what they were feeling and what their solutions were. What did they say? I said, you sit around the coffee room and you say, why don't they just whatever? Well, we're they. So what could we do to make your work environment better? What could we do to be more responsive, more reliable for Nova Scotians? And so from those comments and feedback in those sessions, we built Action for Health, which is a strategic plan for our healthcare system that we have, and it's accountable. We have a website that takes metrics. We're growing and maturing in terms of how we measure, and that's reportable to all of you, available to all of you. So we continue now to come out into community, tell you a bit about the progress that we're making, areas where maybe we wish we were making better progress, but we still feel that we are, addressing in a certain way, but also to hear your ideas. What does your community need? What are some things that you think would work here? Maybe you're wondering whether or not we're doing something or trying something, and we want to know what some of those things are. We know there's a number of issues in healthcare. We know we have a big hole to fill back in, but we are committed to doing that. So tonight, while we want to answer your questions, we also really want to stay solution focused and hear what are the things that you think or you wonder about whether or not we're addressing. So I look forward to the conversation. I look forward to your suggestions. It's going to be all hands on deck, your hands, my hands, our hands on deck to address the issues in healthcare. And so I really look forward to hearing from you tonight. So thank you.
Good evening, everyone. Thank you very much for being with us this evening. I think we're on our 11th of 12 stops, and we did 12 stop of 18. And we've had great conversations in every community that we've visited so far, and we know that we will have another one great one here tonight in Port Hawkesbury. Just picking up on a couple of things that the minister said. We're very proud of Action for Health, our strategic plan. And I think that what I would like to emphasize about it and what we'd like to talk to you about this evening and hear from you is that we know there are a number of you who would be here with us tonight who've probably waited much too long for certain services. You may not have a primary care provider, and you all probably have some kind of a story that you could tell us, and as the minister said, probably a potential solution as well. But to get to those solutions, we can't just keep doing the same thing that we've been doing until now, that we can't tinker around the edges anymore, that what Action for Health we hope will do for us is to bring us to a transformation to a world-class system. So that's really our commitment to you through Action for Health, is that we want to have a world-class health system for you and for all Nova Scotians. So we've set up the format as question and answer, but really we want to have a discussion with you, a back and forth dialogue. We've learned something, as I said, everywhere we go. We're not waiting until the end of all of the sessions to start acting on things. Most mornings after, Karen and I have a conversation and there's something that she's going to follow up on or something that I'm going to follow up on. So please know that what comes of our conversation tonight will be acted upon as soon as we can. So I look forward to the discussion.
Great, thanks. Hi all. At the end of the day, it's all about the people. It's all about the people. And it really doesn't even matter what sector. But right now, in the healthcare sector, it's really all about the people. And so I'd like to start by just having a show of hands for the healthcare workers here in the room, just so we know who's here. Past and present. So we got a few. Okay, here we go. Now we got some hands and a lot in the back. So big show of hands in the room, and I would like to start by saying thank you. Thank you to those who are in the system currently. Thanks to those who devoted probably many years of your working career to the health and well-being of Nova Scotians. It's a challenging time, and I just remind people that almost 3 years ago was the front end of the pandemic, and it's hard to believe 3 years have gone by this quickly. But at the beginning, the healthcare workers in the room and their colleagues were the heroes. And people were banging the pots and waving flags and giving out Tim Hortons cards, and somewhere along the way, that just seemed to stop. And now it's a completely different story. Our healthcare workers are seeing, they are frustrated, they're seeing frustration, and folks are not always as patient and kind as they need to be. And so I just want to acknowledge again the work and the effort, and thank you for what you do. Thank you. Yes, thank you. So with that, I'd like to ask a couple of our local leaders to come up here and introduce themselves. You can decide, Brett, who you want up here. We got a little team there. They were introduced themselves last night in Glace Bay and this afternoon at Inverness, and I think it'd be great to do it again tonight, just so you can see who they are and know what they do and what they do for you. So over to you, Brett.
So good evening, everyone, and thanks for coming tonight for the conversation, and look forward to the discussion. Brett McDougall. I'm a registered nurse. All my years of taking care of patients was in the emergency room setting, but I've since moved on to management and administration. The last number of years, I was the executive director of operations for Eastern Zone. Most recently, taken on the position of vice president for Eastern Zone just in the spring there. So happy to be helping to support our teams and working with our teams in Eastern Zone. So that's Antigonish, Guysborough, and Cape Breton Island. From North Sydney, born and raised there, and just probably live about 10 kilometers from where my house was and my family when I grew up. So really, we're really interested in trying to, as Karen, Jeannine, and Minister Thompson had mentioned, look forward, not really look back in the rearview mirror here. We know there's a lot of challenges that have built up over time, and we're looking for how do we move forward and look for solutions and improve the system. But it is going to take some time and some effort and some patience. I think we have a great team here in Eastern Zone. We're supported provincially with counterparts in the other zones and with Department of Health. So I think it's the right steps forward. Working in tandem together versus in sort of separate parallel paths. So a lot of opportunity, I think, going forward in the future. Obviously, Straight Richmond facility is a vital part of our system here in Eastern Zone. It's a sort of a key pillar, cornerstone. And I know most recently up in that area in the last probably 6-8 weeks with the support from the community, the foundation, Joe Shannon, in relation to the renovation. So a huge thank you to everybody from the community in relation to the support to that facility, and then the contribution from Nova Scotia Health and the province. Walk through. I think the place looks great. It's refreshed, more functional for the team. And I think it will help going forward in the future. But I'll stop my ramble here and hand over to Dr. Bryan.
Thanks, Brett. My name is Don Bryan. I'm the medical executive director. I'm an orthopedic surgeon. I've been working. Brett didn't say the years, but Brett and I basically met 25 years ago in the emergency department. He was an emergency department nurse. I was an orthopedic surgeon. And it's interesting that we're both here today. I think we're both here today for the same reasons. I'm still a practicing orthopedic surgeon. I do have attachment to this community and to this hospital. When I first came here 25 years ago, I wanted to get out into the communities. I was coming here on a regular basis. I was coming here once a month for years and years. I've got to know a lot of people here. Some people travel to Sydney for surgeries, for treatment. Whenever I walked in the door here, oh, now that you're here, would you mind looking at this or looking at that? So it was a great opportunity. I did take a leadership position, and unfortunately, that took up some more of my time, and that's why I stopped coming here, but I had a large group of patients. So this place is important to me, and I know the situation it's in right now, because I did see it 25 years ago when it was alive and vibrant, and I do see a change now. That's concerning. That's why we're here today. That's why I took this position, to get the physicians and the doctors. That's what I represent in our eastern zone, is the physicians and the doctors. But it's come up a couple times already. Is, you know, the physicians and doctors, we do have a seat at the table. We do, and it is a team. We do not do things on our own. We see what needs to be done. We are physically treating the people, but there's nurses, there's business people, there's administrators, there's very smart people in this group, and I love to see work. I love working with them because it is a team, and we are doing some good work, and we have an opportunity now with this government to actually make some steps. The healthcare system, it is not in great shape, but I think this is a great opportunity to do something, and so I am excited about that. I know where we are today. I know where Straight Richmond Hospital is today and the community is today. I want to hear what you think, what you know, and we're here to listen. And it's great to see this many people out here on Friday night. Thanks.
Hello, my name is Glenn Cox. I'm the Executive Director for Community and Rural Health, and also have responsibility for a number of allied health professions such as pharmacy, lab, and DI. I'm a pharmacist by training. And as Dr. Bryan has mentioned, I also worked throughout the Straight Richmond Hospital probably about 20 some years ago, when it used to be under the old Eastern Regional Health Board. So worked a lot with some of the staff members, met some that are in this hall today. And we know we have some challenges. I was at the meeting with, the foundation meeting when we opened up the Ruth Shannon Ambulatory Care Clinic. Very positive news. But we do know we have some challenges, and we heard that at the meeting, and we're working hard to get the hospital back to where the community needs it. And I think that was made clear at that meeting. This is a very integral part of the community, as well as the hospital and other services such as primary care, physicians. So just that we're committed to getting that back, and I want to mention that. I also do want to recognize Andrew Heighton at the back of the room. He's the Director for Integrated Health, working closely with the facility here and the staff, so we can meet some of those challenges and get us back to where we need to be. Thank you.
Good evening. My name is Michelle Podesta. I'm the Executive Director for Acute Health Services and Primary Health Care across the zone. I've been telling everyone I'm still a new Cape Bretoner. My family and I moved here 2 years ago from just outside of Vancouver, looking for a quieter life with our kids. And I think when we first moved here, our kids weren't so sure, but I've been telling everyone our 16-year-old tells us that it's the best thing that we've ever done for her. So that's good news, and really proud to be part of this team. I just want to acknowledge Gina sitting over in the crowd. One of the things, the Deputy Minister said earlier was, we have to do things differently. And one of the things that we've been really looking at, more so from a primary care lens, is how do we do things differently? I think our trying to recruit nurse practitioners and family physicians and our allied health to support a collaborative practice, we need to be able to do some things different. And we've really been working with Cape Breton South Recruiting for Health, and really just trying to be innovative. So really excited to be here this afternoon, or this evening rather, and looking forward to the discussion. Thanks so much.
Great. Thanks, team. Really appreciate it. And now, Nancy, over to you.
Okay, I feel like this is what we've all been waiting for part of the night. So just before we get started, there's just a couple of notes I wanted to make. You notice that we don't have masks on up here, and I just wanted to acknowledge that, because with the mics, it doesn't record really well. We tried at the first sessions with masks on, and it didn't record well, and we got in trouble, so we had to take them off. Some of the questions, like I mentioned before, were submitted ahead of time, and so we'll read those. And I just have so just from a process, depending on how busy it is, if we run out of time, I would ask you to write your question on a card with an email or a phone number, and someone will get back in touch with you. So we will be ending on time tonight, and not just because my son's playing hockey across there. but we will try to get to everyone we can. The other thing that I think would be helpful would be if someone's already asked your question or a similar vein question, if you could let someone else ask a different question, and then we get a better breadth of topics covered. So if that's possible, it would be really great. So if someone asks your question, I know it's sometimes disappointing because you really want to be the one to ask it, but we would ask if you could let someone else go. And then if no one else wants to go, we can potentially ask a different vein of the question, I guess, if that makes sense to everybody. And can you tell that I used to be a teacher? Because I'm like, is that okay with everyone? And I look for head nods. And I will also say there will be some pointing because I don't know how else to keep track of it without like saying, you know, you in the striped shirt. So I do have to do a little pointing to people. So I'll try to make eye contact with you, point to you, and you can nod, and then we'll count off and try to make sure we get everybody. So I'm going to start with a submitted question, actually. This is how we get warmed up. And it gives you a flavor of the kinds of questions that people have sent in. So this one is, what is the Nova Scotia government doing for retention of frontline healthcare nurses, physicians, allied health, who have 10 plus years of experience?
Oh, where would we even begin? Okay, retention. So it's a broad topic. I'll jump in. Usually when I talk about retention, I also go to recruitment. But you know, if we were going in order, it would have to be retention and then recruitment, because the folks that are in the system today have put their blood, sweat, and tears in. You know, deserve to be respected and valued and all the rest of it. So we do a number of things depending on what particular healthcare worker that we might be talking about. A lot in many of the sessions that we've had, it comes up quite a bit with respect to nurses. So I'm just going to maybe start with nurses. It's tough to be a nurse these days. Really tough and very competitive in the marketplace. So particularly our younger nurses can go anywhere they want to go. They can go to any province. They can go to Texas. They can be a travel nurse. They can go on a cruise ship. You know, there's so many opportunities because everybody needs nurses. And so what I have said over the last few town halls to our nurses is that we were heading into collective bargaining with our nurses in Nova Scotia. I have a niece, she's 27. She's a second-year nurse. She's a cardio. She works in the surgery in Halifax. And there's not a week goes by that she doesn't say, you know, in Newfoundland, they're paying this. In PEI, they're paying this, wherever. She makes sure I know, and actually that's helpful. And I do like to understand, you know, what she and her friends are talking about, because they are the future. So as we go into collective bargaining, I think it's very important to note and to understand that if we look at Atlantic Canada, we're the biggest province, we have the biggest hospitals, we have the biggest population. We have the most experienced healthcare workers, really, because we do have the biggest teaching hospital in Atlantic. And so, you know, all of our healthcare workers, and in particular, you know, our nurses, need to be fairly compensated. So compensation is an important part of retention, but it's not the only thing. And I want to, you know, talk about the fact that the lifestyle, to be a nurse, particularly right now, it's very difficult. I think here in this part of the province, probably even harder, because we need people. So folks are running short. They are short-staffed. They're running hither, thither. They're being redeployed. Any number of issues, and so part of what I think we really need to do is find ways to, what's the best way to put it? Nobody can work like that all the time for their entire career. You just can't do it. So we've got to find ways where nurses and other professionals are able to get a break in the action. So, you know, this is conceptual only, but finding ways where they could be cross-trained so that maybe one part of the job's a little harder and one part of the job's a little easier, but it kind of evens out, just as an example. We have to find ways to break through that work-life balance, because we've got nurses right now who, they go home for supper, say hi, go back to work. Go home, walk the dog, go back to work. Like, this is not a sustainable lifestyle, okay? That's the bottom line. So on the retention, the best way we can help them is to get people, which goes to the recruitment. So I'm going to stop talking and let somebody else talk about recruitment. I'll come back to it.
I'll start, yeah. Okay, I'll start. So right now we do have so many vacancies that people can actually kind of work wherever they want. So it's and so we need to reduce our vacancies. And so one of the things that we're doing, we need to grow our own workforce. And so I've said at every session and any chance I have an opportunity, if we want to keep our youth and young people and mid-career folks that are looking for a change in Nova Scotia, healthcare has any and every opportunity that there's available. So when we look at folks needing to go away to work, we don't, if you want to work in healthcare and you think it's for you or your child or your grandchild or your nieces or nephews or whoever, there is work here. And so we really want to recruit. And I know we hear a lot of negative things in the media sometimes about healthcare, and I don't want to discredit that at all. But what I do want people to know is that, you know, healthcare, nursing has been a very, very meaningful and noble career for me. It has been, you know, what I've loved to do. And I think there's lots of opportunity, and there's an opportunity to be with people and help people on their best and their worst days. And so I would just like to get that message out that there is some tough days, but there are some really wonderful days in healthcare, and I think our youth need to know that. We do have the Office of Healthcare Professional Recruitment, and they have a keen eye in working with Nova Scotia Health on how we bring all different folks to the profession. So we've increased our ability to train through our university and community colleges. We've got an MOU with an organization called Michener Institute that will help us train some allied professionals. We also want to look at where there is a career ladder in a certain profession. So as an example, paramedicine. If you're a primary care paramedicine and you want to become an advanced care paramedic or a critical care paramedic, we want to make those pathways really clear and easy to you so that as you maintain or gain your competencies, there's an opportunity for you to move on if that's what you want, so that we want to continue to invest. We also need immigration. In migration, so if there's people that want to come home, we need to make the credentialing process easier for them so that it's easy for them to come back. And similarly with internationally educated graduates, we need to work with our colleges to make sure that folks can come here, that their credentials are recognized, and that they're able to work to the fullness of their ability. And sometimes it's people who have grown up in a different part of the world, but we have a lot of Nova Scotians who have trained internationally, particularly physicians who have trained in Ireland or SEBA or Australia, and we need to make sure that they see a clear pathway for them to come home. And we've been able to work with their residency program to identify that we have Nova Scotians who've been trained abroad, and we want to identify those folks through the matching system to make sure that there's opportunities for them. So there's a number of different things that we're doing, and they're going to take a little bit of time, particularly if we're going to grow our own. And the beauty of bringing people in who are immigrating or in migration is that instead of just having novice practitioners all entering at the same time, we actually have mid-career people, you know, that have some years experience who are coming and bringing that, because one of the things that we need to do for retention as well is to support our novice practitioners, because it can feel quite overwhelming. I remember it is quite overwhelming in the beginning, so making sure that we have we have the right people in place to support our novice practitioners. So those are some of the things that I would point to.
Yeah, I'll just add a couple of last things. Earlier last fall, the Premier announced that all graduating nurses would get a job offer to work in the province here for the next 5 years. So that's a huge effort that we're making to try to keep our own graduates here in the province. Also for continuing care assistance, that this year the province is paying the full tuition for people who want to go to get their continuing care assistant qualifications. And we saw the class number jump, correct me if I'm wrong, Minister, I think we had 200-ish last year, and it went to over 1,000 this year. So it was it was an excellent move, and we're really looking forward to those folks graduating. And then just the last thing I'd like to speak about is community. And on the physician recruitment side, we announced recently that there's a $2 million fund for community groups to access to assist in recruiting physicians. So working with local community groups, perhaps your foundation, and the recruiters at Nova Scotia Health to bring people into your community. So that fund was available for for groups to apply to now. I think it's closing shortly, but I think it's early into December. And then the last thing on community is, we like to say that all of you here are recruiters and people who can retain workers for us, because we know that people setting roots in their community and the relationships that they make within the community is what really keeps them there. So just really important, if you know that someone new is coming to your community, a new practitioner, whatever they may be at the hospital or in one of your primary care clinics, that please try to make them feel welcome, and because that's what we know is definitely what's going to be able to keep them.
Okay, so now I'm going to pass it over to you, and we do have our mic runners. I don't know if I mentioned that last time, so you can sit where you are and just put your hand up if you have a question that you would like to ask, and we'll bring a mic to you. So is anyone... I find it's kind of sometimes in the beginning, then all of a sudden all the hands go up and I'm trying to count. Okay. And then it's like I'm an auctioneer too. And then right here, and then right here. Yep.
I guess my question is around the Straight Richmond Hospital. I know that the emergency department has been closed probably more often than it's been open, and I know that's not just doctor shortage, it's also a staff shortage. I'm wondering if you've looked, I know there are policies in place which are required before you can open an ER, you have to have that standard met. But when you look at some older people that may have heart attacks or everything, having to go all the way to Sydney or all the way to Antigonish, is there a way that maybe at least for an interim period, that some of those standards could be lowered just a little bit to offset maybe the danger on the other side of somebody having to be transported an hour and a half to one of the main hospitals? Just wondered if that's something you might have considered.
Yeah, well, there's a couple things there. If you want to talk about what's happening, and then maybe we want to talk a little bit about the EHS system. Brett, do you have anything you want to say?
Actually, Andrew's been dealing with the team, or not dealing with the team, working with the team.
Perfect, yeah.
So why don't you, Andrew, take a crack at trying to explain some of the things that we're focusing on there.
So thanks for the question. I'm Andrew Heighton. I'm the Director for Integrated Rural Health. So Straight Richmond is part of my portfolio. So working closely with Rose at the site. So the emergency department, we have one physician currently that's providing care for the emergency department, and Dr. Hansball provides 48 hours of coverage. So we do have 2 full days out of the 7 that we have a physician to provide coverage for. So that's one thing. Nursing-wise, as you mentioned, some closures are due to nursing because we don't have emergency-trained nurses in order to open up the department, so we can't provide the level of care we need to have an emergency department open. So we do our best to modify and shift the schedule, and the staff is phenomenal to change their shifts. And as has been mentioned here, they'll come in and do extra shifts, but sometimes it's just they can't do that extra shift, and they want to stay home and walk their dog and see their kids. So those things do happen. Unfortunately, we do have to close or not open the emergency department for that time. So those are 2 of our staffing things we're working on. We do, I will say, in a positive note, I know we have, two registered nurses coming in the new year, spring. We have a couple LPNs. So we are seeing positivity with recruitment to the site, working hard there. But also with the emergency department, there's other things we're working on with virtual care. Jan Summers' team with the virtual ER. We did do a pilot at the site with that team, and they are coming back, so we were able to hire ACP and a ward clerk that will be able to work and provide virtual care through at the St. Sorry, I got a cough and a cold. At Straight Richmond, so we're working on providing virtual care. So when Dr. Hansball is not there, we're looking at to see if we can offer this virtual service for emergency, less urgent needs during the days that we don't have a doctor on site. We'd have a doctor on an iPad. They could be in Truro. Dr. Tanya Sullivan is working with us. She'll provide some coverage as well. So we're just working through that process now to be able to provide that out of the emergency room here at Straight Richmond. And as well with the EHS thing, we do work with EHS a lot. We do work with EHS, and there is they have a physician, and EHS can speak to this better than I can, but we do work with them a lot, and we do have opportunity to provide care and stabilization if needed in situations. But again, if you're having a stroke or a cardiac arrest, you're not coming to Straight Richmond anyway. You're going to go to St. Martha's for a CT scan or the advanced care that's there, ICU, cardiologist. So if that was the case, you wouldn't be going to the Straight Richmond. You'd be bypassing and going to St. Martha's or the Cape Breton Regional anyway. So in those cases, it wouldn't matter if we're open or not. You'd be going to those higher level acuity hospitals. So, but we are working at how can we provide more opportunity to accommodate lower acuity or urgent treatment at Straight Richmond that we are unable to offer 7 days a week now. So we are working on those things through recruitment and other modalities of care.
Thanks, Andrew.
Yeah.
I think the other part of your question is around EHS, and we have really good representation here tonight. Jeff Fraser works with the Department of Health. He's an experienced paramedic, and I do want to acknowledge Kevin McMullen, who's the president of the paramedic union. I always get the letters mixed up, Kevin. I apologize. So I just say the union. And so we're grateful for our evolving relationship, trying to work directly with those who are at the front line to address some of the issues in the EHS system. So grateful for both of these fellas. And we'll turn it over to Jeff to talk about some of the work we're doing with the EHS.
So there's no doubt we have some challenges that we are facing head on in the EHS system. I've worked over 3 decades in the system and left and came back I was an operator, came back as the regulator. And so I hit the ground running about 7 months ago, and we are full bore trying to make the adjustments to our system that need to be made. So we've got some capacity challenges. We've got some staffing shortages that impact us, and there's no doubt things like closures increase our time on task, but we are continuing to make these changes. And one of the changes I'll share with you is, I won't throw a bunch of numbers, but I'm going to throw a few out there. About 70% of the patients that we see in EHS are what we consider to be low acuity. So some of these folks need to go to the hospital, some of them need a care plan, and so we just added a nurse that started working in our communication center 2 days ago. This has been a program we've been developing over the last number of years. It has been successfully executed in other jurisdictions and has had a major issue or major impact on some of the issues that we're facing. Andrew had alluded about the physician in the communication center. So paramedics always had access to a physician, but the physician might have been on call. November of last year, we started a new program where we actually put a physician in our communication center 24 hours a day, 7 days a week. When I talk about those 70% of those folks that may be low acuity, taking those people all directly to an already overcrowded and busy emergency department doesn't necessarily, it's not patient-centered, doesn't help them, doesn't help the other people in the system. That physician has the ability to put that person in a virtual waiting room, and then we check back when we can do it. So we're just really getting into this now. So in our communication center, we have some former paramedics. We have some lay people that have been trained to work in there. We have a very clinically competent paramedic who works a mixed practice in the communication center and out to provide support to the paramedics that are on the street. Also to help interpret and guide some of the clinical decisions that need to be made now with the nurse and the doctor that work together in the center. Some of the other initiatives that we have underway is that our system was built to have all of our patient transfers and Our paramedics do all the transfers and all the work, basically. We're one of the few jurisdictions in Canada that didn't have a transfer service. So over the last year, we have really focused on taking and separating out our transfer service. The minister alluded to about laddering earlier. So we recognize there is a shortage of paramedics in Nova Scotia. There's a shortage of paramedics in Canada. There is a shortage of paramedics in the world. So we have to do things a bit differently. So about 40% of the work that we do are inter-facility transfers out of our call volume. We know that there are some patients that do require clinical care en route, but not all. And so a year ago in September, about 86% of all patient transfer movements that were done in the system were done by paramedics. And as of October this year, we're at 20% already. And I'm really pushing our team that we believe now that we have these resources in place that we can get that to 5%. So what does that mean? That means it increases a great deal of capacity in amongst our system for our emergency and urgent calls. The 30% of the patients that are sick, we want to make sure we're there for all the time. This is going to be we're starting to see this fundamental shift. Now, we had a tough week in the EHS. We hit a milestone this week. We do about 560 calls a day. That's usually what happens. But a day earlier in the week, we hit 828 calls. So that's hard to keep up with. So the focus that we have on making sure that we provide the right practitioner to the right patient at the right time is key. And so this is what we will do. It's a big deal to make the changes that need to happen. I've described it like turning an aircraft carrier with a paddle, but we are making progress and heading in the right direction. So we'll continue to work on those things.
Thank you. I think we have some at the back. Yeah.
Oops, I thought I lost my chair. Thank you. I just wanted to say that to start that paying for the CCA education is a great idea. So good job on that. I have two questions, and I'm hoping I can ask one, get the answer, and then my follow-up may change. So my first question is, in other places across Canada, nursing staff, or I guess healthcare workers, were not mandated to have the vaccine. We were in a health crisis with needing it, so why did we mandate the vaccine?
So that was a decision, the mandates happened prior to us, but certainly we followed the advice of public health. And at the time, this is the path that the province chose, and we continue to follow that path. So the mandates were implemented as a way to protect and keep Nova Scotians safe.
Okay, so that helps with my follow-up question. So we mandate the vaccines, we get rid of the ones that don't want to be vaccinated. And then, if they go apply at the VON, they can work unvaccinated, fill those unvaccinated positions for an extra $10 an hour plus travel expenses. I'm not seeing the common sense in this.
I can't speak to the VON. I really don't know.
You should check into it, because that's how it's unfolding.
I'm going to make a note. In terms of, I don't want to argue, that's for sure, but at the moment, the non-vaccinated healthcare workers are on leave of absence from NSH, and I think if you read the post today, you probably would have seen the numbers, which were current as of Monday. So in Nova Scotia, we have 127 healthcare workers who are not at work at this moment because they are not vaccinated, and another 7 at the IWK. So 127 at NSH on 26,000 employees, and 7 at the IWK. So there's no intent at this time to change that policy. I'm going to make a note and check on the VON. I really don't know the answer to that, so thank you.
Thank you. Sorry, now I'm pointing to everybody. This gentleman here.
I have a few questions. My first thing is that I'm from Almadam.
Can you hold your mic up to your...
I'm from Almadam, Richmond County. And we have a situation where We have 3 doctors, 2 of which are father and son, and they go on vacation. They've done this 3 different times. The last time for 10 days, we have no doctor coverage. I don't have a problem with them going father and son. What I have a problem with is why would the minister not provide a locum to the 3rd physician that has a defined license and could provide care for our community? I think that's a step that we need to take if we're going to solve problems for us anyway. The other thing that I would like to see is why would they not be required to have a replacement? Then at least we'd have coverage. My 3rd and most important one is, and I'm not sure if the gentleman was referring to this, why would we not implement the paramedic model where we have a nurse practitioner and paramedics that have access to a doctor, that St. Anne's Center, for example, and Straight Richmond could work together, which they don't, but they should, work together to try and provide services. The other thing is we have 2 doctors in Lardoise, 2 or 3, and maybe 4 in Port Hawkesbury, 3 in Arishat. We have at least 1 or 2 in the hospital in Straight Richmond, serving 10,000 people roughly. Add to that 2 nurse practitioners, 1 which is not practicing, God knows why, she's not allowed. And there's no one available after 4 p.m. No one is doing home visits. No one on weekends. No emergency in Arishat or Straight Richmond for at least, I think, 50% of the time. So we definitely have a problem there that could be solved by thinking out of the box. Also, I'm told, maybe I'm wrong, that the reason that the ambulances take so long to get to the person with an accident or whatever is because the beds in the Antigonish or Sydney are full of people who should actually be in St. Anne's Center or that type of home. Now, if that's the case, we at St. Anne's are looking for a new build. We've been approved, as far as I know, and we're limited to 30 beds. It doesn't make any sense. Why not give us 35 or 40 beds? We have a list of how many? I think it's a 3.5-year waiting list. You know, so put the money in the project and get these people to have good health care, and then turn around and the ambulances can come back. There was an accident with 2 young people next to my place, right next door. So I went out, I asked the girl, did anybody call an ambulance? Yep, 40 minutes, we'll have an ambulance. The ambulance came, 40 minutes on the dot. The 2 young people were on the cement, or the pave, I should say, laying down. Luckily, we had a nurse with the fire department that was really an asset. Now, the ambulance came, picked up 1 patient. The other patient was on the cement or pave for another 40 minutes. 80 minutes. There's something wrong. And I asked, well, what's the problem? Well, we don't have enough ambulance. And again, they told me that the hospital in Antigonish was overwhelmed with no beds. So the ambulance was parked there waiting. So if you really seriously want to solve the problem, those are the problems we need to address yesterday, not today. And we got to think out of the box. And you have to make a decision and be brave and say, this is what we need to do to solve the problems. So anyway, my last thing, and I wrote them all down so you have them anyway, but oh, yeah, this is a good one. No, it's even in New Brunswick, you know. You go to the doctor, you have 5 things that bother you. Doctor says, well, wait a minute. We got to give you the results of the blood test, but you got to make 4 more appointments to come back, and then we'll deal with each one. Now think about that. If the doctor took 15, 20 minutes, and I don't understand, maybe it's about the money, that's what people tell me, but if they had dealt with the 4 extra appointments, if they serve 1,000 a month, how many how many patients would be able to have a doctor now? You know, like I don't get it.
We're going to help you.
Good, I'm listening.
That may be the last question of the night because there's about 25 in there.
Yeah, I don't know what happened to the 3.
So I'm going to start. I'm just going to try and peel away parts of it, and we'll I know between all of us we'll figure it out. So first, I want to talk a little bit about long-term care. So prior to being elected, I had the opportunity to work in long-term care, and one of the things that I'm very proud of is that when we were elected, we have a minister now of seniors and long-term care with a dedicated minister, dedicated staff, and dedicated funding, which is really important. So we know that there are a number of people sitting in hospital beds, living in hospitals, waiting to go to long-term care. We need more beds. And we've committed to that. And there are new builds that are happening across the province. We are trying to increase the number of beds. The other thing that was happening across the province was because there's an overwhelming lack of continuing care assistance. So there were actually empty beds throughout this province that we were not actually able to fill because we couldn't safely staff the beds. And I'll tell you, the people that work in long-term care are gifted. They are experts in working with frail elderly people and people who live with chronic diseases. And so one of the things that we did very early on in our tenure was increase the wages for continuing care assistants by 23%, which was significant because it pulled people, A, back into the profession, and B, it allowed people to see that as a viable career path for them, which is why when the deputy mentioned, we went, like I don't know the numbers exactly, but I think in 2018, 2019, and you can help me, like maybe 6 people graduated from NSCC from the continuing care, and Annette needed them, and I needed them, and Carson needed them, everybody needed them. So now we have an enrollment in this province of 1,000 people, which is really going to help us open all of the beds. Also, we've worked with the province, to make sure that we can train our own CCAs so that we have the workforce we need to support. And we also have committed to, as a government, increasing the hours of care because when I worked at RK McDonald, they have a picture of the very first person that moved into RK McDonald, and he parked his car, he had a trench coat, and he came in with the black bag. Like, that isn't happening anymore. These are really frail folks. And so we've increased the hours of care that residents in long-term care facilities receive to 4.1 hours of care, and that's huge. So I do want to let you know that there's a lot of work happening in long-term care to strengthen that system and to make sure that the people who are in the hospital are able to get to skilled nursing facilities as they have before, and also working with long-term care. So during the pandemic, we didn't transfer very many residents to the hospital, right? Because of the pandemic planning, we needed to keep things. And so as organizations, we worked really hard with physicians and nurse practitioners to keep the residents there and give them the care they needed. And so that has continued to carry on, but we can do more there. And we can work with our paramedic colleagues to come in and offer special patient programs, and we can have them come in and do some interventions with those residents in order to keep them in their homes. So there is a lot of work happening, to your point, but it is going to take some time. Those buildings need to be built. In terms of the physicians, so the doctors that many of us had in this room that are my age and older, we had physicians that were seen they were paid by the patient, but they did everything. They delivered us, they did surgery sometimes, they did it all. They worked in Emerge, they worked in their offices, and physicians are trained a bit differently now, and I can't speak to the exact details of that. But those older doctors, our more mature doctors, are different than our novice physicians. And our older physicians might have had 3,000 patients, but now the newer physicians want to work in a team, and they want to have between 1,300 and 1,500 patients. So it almost sometimes is a nurse practitioner and a physician to one of our retirees. So it's just a different way of practicing because we're more complicated. We have more medications, we have more diseases, we have all kinds of different things as we age. So that's one of the things that we're working on. We're also giving doctors an opportunity to kind of choose the payment model that they want. So some doctors want to be paid by the patient, whereas others want to work on a salary. And so we're working around the accountability framework for that. So what are the number of patients that you would see in a day? And we would adjust it for the number of complicating factors that we have. So it isn't a replacement of one-to-one anymore, But we also didn't have nurse practitioners in the old days. And so we know that there's a workforce there that we can continue to grow. We know that we heard that through the tour that there were a lot of unemployed nurse practitioners. So Karen put something on her LinkedIn and got 50. So we know that there's latent capacity. So we do want to use all of our practitioners, like, you know, pharmacists and nurse practitioners can now work together in a model. We want everybody to use all of the skills and competencies that they had. So it is going to look a little bit different. So those would be two of the things. You'll be sick of listening to me talking. And then I don't know if someone else wants to talk about some of the other issues around recruitment. And does that help, some of that? It's coming. Don't answer. Wait. We're going to keep going.
No, I think the only thing I'd like to pick up on is a few of the things you said is, you know, why aren't we doing this and why aren't we doing that? Which is, we are looking at everything. And I think that that's what's really important for people to understand, is it's not going to look the same as it always has. And so as we look at these new models, as we look at how people want to practice differently, you're going to have to be prepared that it's not going to look the same. But what we're working for is to make sure that you have access to the right care at the right time by the right practitioner. And so we all have to get our head around, though, that it is going to look different. It might be a different type of health home where you don't always see the same practitioner, but you might see the physician when you need to see them, or the nurse practitioner, or the dietitian, or the social worker, but we really want you to think outside the box with us, right? And think about, you know, are you getting care that is there when you need it? Is it ready when you need it? Is it reliable when you need it? And is it responsive to what your needs are? And that's really what we're working toward for you. But we do have to say that it is not going to always look the same as it has to date.
Yeah, I'd like to maybe pick up on 2 points. One, just kind of scope of practice. And actually, had an opportunity to cross-examine Trevor Boudreau at dinner tonight. And, you know, Trevor is a chiropractor. Not a pharmacist, but your wife's a pharmacist. So just talking about, you know, the scope of practice of a chiropractor. So, you know, I got a one in Halifax. He's able to order an X-ray. But you can't do that all across Nova Scotia. Well, that's nuts. Like, that to me is nuts. Either do it or don't do it. So I don't know the answer. We got to find out. Right? Got to find out. Then we go to the pharmacist. So the good news about pharmacy is that through the pandemic, of course, you know, I think people were well able to see that the scope of practice for a pharmacist was a lot more than it was before the pandemic. And they have a whole lot more that they can do too, by law. So, you know, if you're an independent pharmacist, like Trevor's wife, Sarah, who I've not met yet, but I feel like I know her pretty well now, since I cross-examined poor Trevor. You know, she's a diabetic educator, and she in her pharmacy, she can pretty much set that up however she wants to set it up. So she can do the kinds of niche things that she wants to do. I go to a pharmacy in Halifax. It's Lawton's, and there's a home care in the pharmacy, which recently the pharmacists had to take over. So they're doing, you know, they're doing different things. They didn't really want to take over the home care part, but they did. And every time I go into my pharmacy, they say, "Oh my God, Karen, are you giving us more to do?" So we also have to be a little bit careful about that. But that's not us per se, that's also the employer. So, you know, pharmacists can do more, and we can choose many other healthcare providers, whether it's the physio, the OT, you know, name it, and everybody can do a little bit more. And the challenge, what we haven't done well in this province, is have people working to their full scope. So just think of the chain. You know, you got your CCA, your LPN, your RN, physician, you name it, OT, PT, pharmacist, paramedic, and so on and so forth. So if they're not working to their full scope, maybe we have this much. They're working to their full scope. All of a sudden, we have this much that we are able to do with the same people. Okay? So we're working really hard on that because that's kind of a no-brainer. Now, one of the things that we're really interested in seeing how it all pans out after the hurricane, I'm going to say Katrina, but it was really Fiona. After the hurricane, we were very quickly able to put a mobile bus together. And we sent it down to, it was in Sydney. It was on Member 2 for 2, 3, 4 days, I think. And that bus is going to stay in operation this weekend. We actually have 2. One's in Digby and one's in Yarmouth. Last weekend, one was, they were in Kentville. They've been in Antigonish. I asked Trevor if he thought it would go well here. He thought it might. I hope you agree. So what we're able to do with the bus, though, is depending on which community, like different communities have different needs. It's not all the same. So you can put different providers on the bus to see what works. What group of people can see the most patients? What what mix is most effective? How do we make this work as effectively and efficiently as possible? So what we have found in, I don't know, 2 months or whatever it's been, we had the bus at Cobequid a couple of weeks ago. They took 126 people over 2 days, and those were folks that otherwise would have been in the ER at Cobequid. The same, no matter where we put it, there's many of the folks who otherwise would have been in the ER. And just understand, these aren't people who don't have a family doctor. In many cases, they have a doctor. They just can't get in to see their doctor. So we're able to do a little bit of what we call test and try. And so, these are the kinds of things that we're putting out there, we're trying. If it works, we do more of it. If it doesn't work, get rid of it and try the next thing. Like we really are into almost an entrepreneurial mindset of seeing what will work for Nova Scotians. So, these are the I guess, innovations that they're not that hard to put together. And they're out and they're on the road and they're on the go. So.
I just wonder if you, Dr. Brian or someone from NSH, if you want to talk about the locum issue that he mentioned. I don't know if you heard the whole, Karen, here's your pen. The whole issue around the locum and the physicians would be great.
Yeah, definitely. There was a number of questions there, and I think I got 6 or 7 of them. Yeah, yes, I do. And that's why, and thanks for your questions and your comments, and they're all valid. And as a physician, I would like to address every one of them. The first one is, and you mentioned yourself, they deserve to go on vacation. Yes, they do. When I go on vacation, I go with my family. And the issue is, though, that I've been to that clinic, and July 1st and 4 o'clock in the afternoon, they're not with their family. They're probably in the clinic. They're taking care of people. They go above and beyond every day, so they need to take vacations. They are continually frustrated. They're calling me. We want to go on vacation. We need to go on vacation. We want them to take a vacation. We want them to recharge. We want them to be in a good state of mind when they come back. They simply can't find the help. And that's the issue. We simply can't find, we talk about physicians and diagnostic imaging specialists, lab techs, physiotherapists, everybody. There's a severe shortage. We simply can't find those individuals to come in and fill in. What I've seen in the last year in the province has been a complete shift. There's a whole team, there's probably 16, 17 dedicated people to recruiting physicians, nurses, lab techs from the province, from all over the world, all over the country. It's completely changed, but despite that, we're still severely short here at Straight Richmond. We're severely, severely short. We're working very hard to recruit people. We simply are not able to. We're competing against the rest of the country. I think we're, in the province, I'm comfortable that, we're saying we're recruiting. I do believe we're recruiting to the province. If we can recruit someone to Kentville, I'm happy. We're at a point, the 4 zones are getting along. We're not competing with each other, but unfortunately we're competing with everybody else. So these doctors, that community, they're really stretched to to find people to help. They need to go on vacation, they go on vacation. They're also private, they're private contractors. Nova Scotia Health does not control what they do. They can do what they want. They work hard. Your other issue was you got one problem. I'll see you for one problem. That's an interesting scenario, and it happens. I've seen it happen. I've heard it happen. I've lived it, and I do not believe in that. But guess what they say? When you go to Dr. Brian, you're going to wait 2 hours to see him. Why? Because he takes care of your problems. So do you want to wait 10 minutes, or do you want to wait 2 hours? But the bottom line is that there's the philosophy amongst family doctors now that's not what they want to live by. I think they want to. There's a role. Occasionally, there's a role for that. But I'll see you from one issue. But I do believe that they don't want to do that. But sometimes they're forced to do it. But it's not something they want to live by. And I think it's really something that we've progressed through because of the reason now there's more people. To Karen's point, there's more people able to do more. Everyone works to their scope of practice. More people can provide that service. And the final point is that I really haven't heard it in the last couple of meetings. Is that I've been doing this for 25 years, and Minister Thompson mentioned they were these legendary doctors of 20 and 30 years ago. They were delivering babies. Guess what? There's not many babies being born now. The doctors now are looking after people who are 75 and 80 years old. And once you hit 75, their demands on the healthcare system completely change. And so these new doctors or the younger doctors, they're in a completely different environment. The technology is so much different. What I did 25 years ago is nowhere close to what I'm doing now. The technologies, the MRIs, the diagnostic imaging things we can do, robot, you can get your knee replacement done by robot now. And so the technology has changed. So these doctors are not practicing the same medicine that these doctors did from 30 years ago. So we have to appreciate that, understand that. But now we are thinking outside of the box, and we're introducing all these other individuals that can help with healthcare. And we're hoping that's going to spread the load some.
Thank you. Yeah, exactly. It was a very thorough question. So, yeah, you go.
Good evening. My name is Michael Hatt. I am a local pharmacist and owner of an independent pharmacy and a good friend of Trevor's wife. What? Not Trevor. Not Trevor, no. Used to be my chiropractor, and then he moved away. I'd like to take two opportunities before I get to my question. Thank you for giving us a forum to ask questions. And two, I want to acknowledge the fact that our healthcare crisis was not brought on by this government, but of course previous Conservative, NDP, Liberal governments of the past that didn't acknowledge that this was coming. My question is kind of a follow-up to your reply about pharmacists and other allied health and their expanded scope. And it's also about how you prioritize need for areas such as the Strait area. And the reason I bring this up is I recently applied for a pilot project for our pharmacy because the Strait area was identified as a high need area. But by the time that the allocation for those pilots was done, the Strait area was no longer identified as a high need area. And I'm wondering if you could elaborate on how those high need areas are distinguished, if it's just by the 811 list, because I can tell you firsthand, waiting on a lot of our patients, is very few of them are actually on the 811 list. We do have a more senior population, more spread out population here, and rural internet is also an issue with our clients, so things like virtual care don't work. Love to have them come to the pharmacy and do a virtual care, just FYI. Yeah, if you could just elaborate on how those are picked, that would be great. Thank you.
Again, it's kind of a multi-loaded question, but it's a great question. So I want to start at the back end. I want to talk about the internet. So I want to, yeah, we're going to get, just go ahead. We've been together now for a few days. We got a driver, which is the minister's assistant, Jean, somewhere in this place. She's driving my car that doesn't have heat right now. So could I just tell you, and it's Friday. So sorry for my people. In any event, I do want to talk about virtual care, and then I would like Minister McMaster to please discuss the internet. So you mentioned internet and virtual care, and frankly, folks, virtual care as it exists today, it's good. It's going to be better, and all things virtual are a path to the future. It's not going away. It is going to expand, and it's going to be very important for people to be able to access, to be able to understand how it works. There will be a day coming very soon where you will have a lot of what we're talking about here on your phone in an app in your hand, okay? So internet and cell service become very, very important components to healthcare. So maybe, Minister, if you could just talk about your plans for this area and for the province, that would be a good starting point. And then I'm going to come back to the question.
Well, I think we all know how important high-speed internet is. And I know people who live right in town here, probably not as much of an issue. I think you probably have pretty good internet, but many people around all over the province suffer with poor internet. So the short answer is, by the end of 2023, contract signed in this area with Bell should bring fiber to the home for everybody. And fiber is future-proof because you're using, I won't get into too much of the technical aspects of it, but you're shooting light through cable. And they've discovered you can now actually shoot colors of light. So it's vastly expanded what was already an excellent way to communicate. And it's future-proof, that's what they say. For people, and you can follow this on the internet, so by the end of 2023, just about everybody should be connected fiber to the home. You can check on, there's a website, we can share it with you at some point. You can follow community by community to get an update on when your community will be connected. Beyond that, there are still going to be people who can't get fiber to the home. So the government has subsidized low Earth orbit satellites. It's a shorter distance up and down, and the end result is there's less delay, and it's very good. I know somebody in Craignish who has it, and they rave about it. They get really fast speeds with it. So by the end of 2023, most people in the province should have really good high-speed internet, and if the future is as you say, on your phone, well, then you should have good connectivity coming soon. I want to say something about cell phone coverage. This is kind of something that I always plug, and it's not the official word, but I'm going to say it anyway. We don't have great cell phone coverage, and it becomes a safety issue for people. It becomes, I would say, a recruitment issue. Who wants to come from an area from another part of the country here and suddenly want to buy a home and you don't have cell phone coverage? You know, your kids are complaining, and so on and so on. That is something that I don't think we can rely on the private sector to deliver. If we could, they would have delivered it long ago. There's no money in it for them. The province owns many towers. We've got over 80 towers, I know, at least around the province, because we have communications needs too. Why don't we buy more towers? We could capitalize the cost. It might not even cost us anything at the end of the day. We could lease space in the towers that we put up to all the private sector cell phone carriers. Competition, better prices, better service, and we solve the problem of poor cell coverage. So I think that's the way to do it. That's just my thought. And I hope that we do that as well, because if people are using cell phones, you know, and if they're mobile, they might need to access their health care on the road or wherever they happen to be. So I'm hopeful, because I think that is very critical for everything healthcare, and for people working from home, and for living our everyday lives, because we're in the world now where we need to be connected.
That's great. Thank you, Minister. And I'm now going to ask Jeannine if she'll deal with the pilot project, and then I'm going to clean it all
Is
up.
it the pilot project through the Pharmacy Association of Nova Scotia? Okay, I'm gonna have to, I'll chat with you after and I'll get you a more fulsome answer, because I know the department has been working with them on certain aspects of it, but I'm not exactly sure who determined the criteria. So I'll connect with you offline after and make sure you get a fulsome answer. Okay. Sorry, just for recording.
So I guess the question though is your resources, not just pharmacy, doctor, nurses, the travel clinic. You know, how would we prioritize the straight area? For example, Antigonish just recently in September lost a lot of doctors due to retirement. 25-30% of our clients saw those doctors. Does that get factored into the straight area? Yes. Or is that an Antigonish area? You know, we're looking at the straight area, maybe at Port Hawkesbury at 3,500. If you scope Richmond County down Route 19, we're talking maybe 25,000 people, most of whom aren't on 811. So how do we prioritize the need?
We can start. We'll probably have to get you a little bit more information, but so first of all, to Dr. Bryan's point, you know, physicians, the majority of them are private folks, and so we don't always know when we have a physician that's going to retire. But when we do know, we work with them to the best of our ability to plan, and we plan based on their panel size. So it may not capture specifically, especially if they're still on a paper chart. I'm thinking about the practice that you're talking about, and so they're still on a paper chart. So it's really difficult for us to attach people to postal codes as an example. But what we would look at is the panel size that they have, and we can understand that through their billings, and physician services have lots of different ways to understand that. So it would be looking at that. So it would be a little bit harder, which speaks to the need for the technology, right? Making sure that we have more integrated services so that we can look at postal codes, so that we can look at health equity, making sure that people have it. So there is some health equity work that's happening now in the department and with Nova Scotia Health around a health equity framework, race-based data collection, all of these different things. So there is work happening, but we need better connectivity around that. But we do plan based on retirements when we know, based on the panel. I think that's fair.
Yeah, and I think there's a bit more to it. So we have a lot of data. A lot of data. And we are able to, you know, rack and stack to really get the answers to a lot of the questions that are asked. So, for example, I can have data analyzed to see how many Nova Scotians are either on the need a family practice list or, you know, to see where the greatest needs are. And typically when it comes to recruiting, the areas where we have the greatest need will be pretty high on the list. Okay? That doesn't mean we're always successful, because as Dawn said, if a person comes and they decide they want to go to Kentville, we're not going to say no. But we are also extremely mindful of where the biggest pockets of need are. So I would say need is high on the list. And I might just take a minute to talk about the list. It hasn't been a question here, but it certainly has across the province. And so what I like to just talk about is the virtual care, and then I'm going to ask Jeannine to maybe talk about what we're doing with the list. So if a Nova Scotian is on our need a family practice list today, then you are eligible automatically for virtual care Nova Scotia. But you have to sign up for it. And we have folks here, I think, tonight that could actually help with that. So you're eligible to be on the VCNS, and you just sign up for it. What that enables you to do is to be seen virtually, and that would either be by a physician or a nurse practitioner. And that person, and it works quite well, like there's not a long wait time. You can't do everything virtually, of course, but you need a prescription renewed or something very basic, it works like a charm. Now, the care provider may refer you to a specialist. They can do that through VCNS. Or maybe you need to be seen in person. And if that's the case, you would be referred to one of our clinics. And again, they work quite quickly. In fact, it works sometimes better than trying to get an appointment with your own doctor, which is presenting another problem for us. So then everybody wants virtual care in Nova Scotia because it does work so well for certain things. And so at the moment, it's only available for those on the list, but we have heard enough feedback now that the next step will be to make that available to all Nova Scotians, but it will take time to build it out. It's kind of a massive undertaking, but that is our plan, to make that available to all Nova Scotians. So you've heard lots about the list. We certainly hear lots about the list. So Jeannine, can you maybe just inform folks where we plan to go with the list?
Sure. So we do hear a lot about the list. I'm sure some of you here in the room this evening are on the list. We know there's approximately 100,000 people right now that are on the Need a Family Practice list. The issue that we have with it right now is that it's static, that really someone's name goes on, but there isn't an appropriate triage of the person who's going on to the list, that we don't know kind of if you have multiple health conditions or if you're a relatively healthy young person or, kind of, what your situation is when you're on the list, if you're pregnant. So what we're working to do is making the list more interactive for both you as the citizen and for us in matching you with a provider. So I'd say kind of stay tuned into the new year, but that we are working diligently to make the list a better tool, especially for you, but also for us to be able to help you to get the care that you need and to be able to see who really is of highest priority, that it might not be a first come, first on, first off, but that we have the information to allow us to make more informed decisions about that.
Thank you. So I have a submitted question now that someone has asked me to read. So this is specifically around internationally educated physicians. So physicians from abroad. There are massive obstacles for foreign doctors to receive a license to practice. They have to redo their exams like a student, and the question is why? A lot of foreign doctors are experienced and come from a comparable health system. Is it better to have no doctor than have a foreign one filling the vacancies?
This is the bane of my existence in the sense that I would just, if I could wave the wand, come in, here's your job, let's get on with it. Unfortunately, it doesn't work quite that easily. So we have colleges that we need to deal with. Where I go off the rails here, Don, you can put me back on the straight and narrow, but we have our provincial College of Physicians and Surgeons, and we also have our National Royal College, and similarly for nurses, similarly for other professions, pharmacy and so forth. So the colleges are very, strict around practice requirements and so on and so forth. So let's just focus on doctors for a second. We do have a lot of internationally educated physicians that are either that their families have come to Nova Scotia, they've arrived in Nova Scotia, and they have had the dickens of a time trying to get through the process. The Royal College is working with the federal government of Canada to streamline that process, and in turn, provincial colleges are looking for ways to streamline that. So I'll get this wrong, but our college recently relaxed a requirement for a physician to have to take an exam after, I think they've been here for 5 years. And they may be here on a defined license or some kind of a restricted license. But they can stay without having to take that exam. That's actually a big move for our college, and it puts us in a unique spot, kind of a competitive spot right now to be out and recruiting docs outside of Nova Scotia. So that's a help. I know that our 4 Atlantic provinces are also the colleges of all 4 Atlantic provinces are looking for ways to streamline amongst our provinces. That's being led by the premiers, so that there can be easier mobility and certification as between the 4, which I think is a positive step. So there's a lot more work that has to get done. Our college, our provincial college, has also worked very closely with us to put a couple of new streams in play. So we have a new stream called a clinical associate. Do I have that right? Which, you know, is a more restricted way of practicing, but nonetheless, it opens a door. Okay, so for example, there were a number of Ukrainian physicians who landed in Nova Scotia, and we were able to find spots for them through that kind of a pathway, which was good. And what else am I missing on the international front? I can't.
So we're also looking at competency-based assessments, so practice-ready assessment, so that, you know, we look not only at the bookwork, at the degree or at the, you know, credentials, but when people come and want to work in Nova Scotia, we pair them with physicians so that those physicians can assess their competencies. And, you know, one of the things I think that the Ukrainian nationals have taught us, when you don't have records, like they don't actually, most of them have records because of the, you know, they've had to leave a country unexpectedly, or maybe their records are destroyed. How then do we work with clinicians to look at the competencies that they have and the skills that they have? So, you know, it's challenged us to kind of look at how we do that. So I think it's been positive in that way. And so I think we continue to look at ways to bring internationally educated graduates here. The other thing is we have a number of Nova Scotians who are internationally educated graduates. They go to Britain, they go to Saba down in the Caribbean, Australia to train, and the issue now is that they have difficulty getting a residency, which is imperative that they have that residency when they come back. So we were able to meet with the Canadian residency matching service, and we're looking now at the next stream and how we're able to identify Nova Scotians who trained abroad in order to bring them back and make sure that they can work in their home province. So there is a number of things that we're doing to address that.
And here's the really good news, which is this year in July, Dalhousie Faculty of Medicine will graduate the single largest group of family practice physicians in the history of Dalhousie University. Okay? So we are working hard with them to open those doors in every way possible. So, next question, Nancy, please.
Another submitted question. Back to virtual care. I would like to ask how virtual care can be made more user-friendly. As a person who works on a computer 7 hours a day, you have to be prepared to upload documents, type your issue in, lost contact with the doctor, and hard to get contact back. If I found it difficult, how are seniors supposed to navigate the system?
Okay, great feedback. I think that came here. So, yeah.
Excellent.
So, this is the kind of feedback that we need. So with respect to seniors, I would just share the following. Number one, not all seniors have a computer. Number two, not all seniors know how to use their computer. And number three, they don't know how to do all that kind of stuff. Like it's not easy, as you say. So this I would just share with the community, because I'm just looking at this fantastic building, which I've never been in before actually, seen from the road only. What they did with the Aberdeen Hospital Foundation is they paired with their local library, and the foundation paid, and they set up a kiosk type deal in the library and had a person that can help seniors. Sign them up for virtual care, get them hooked up, get them sorted, work them through it, and it's working like a charm. did the same thing in Bear River, and doing the same thing in Yarmouth. And these were all just community groups, but 2 were hospital foundations. So that might be something to be thought about by some community group, and I bet you this building's pretty well used, so it's a possibility. The other thing, there are folks here from virtual care, and there are folks back at the ranch who can help anybody get sorted. So for example, I had an example 2 weeks ago. A woman in the valley, she had a physician, but her children, 4 of them, lost their physician, different docs. And the children were all under the age of 16. And so we had the dickens of a time trying to get each of the children onto the registry. We did it. So it's finicky. There's some finicky little bits, but there's help, and there's people who will guide you through every step of the way. So I think what I would just say is, definitely don't give up. I would encourage MLAs to make sure that somebody in their office knows exactly who to call and how to do it, because I'm sure you'll get the calls, and you should. So we'll start with that.
I just wanted to add one thing. Thank you very much for that feedback. I think the other thing that we haven't said here tonight either is that on not this one in particular, but on a number of the initiatives that we're working on, people are working at the speed of light, I think is the fast way to say it. So we aren't always getting it right the first time. So we really need feedback like that, because if the more people start using it, and it might be intuitive or to get something going, to get people something as quickly as we can, but then we need to hear when it isn't working or when we could change something, because that's the part of the test and try. It's us getting it out to you as quickly as possible, but we don't always get it right. Like, we know that, and so we need to hear that back from you, as Karen said, to us through your MLAs and that, but just please, like, we are really looking for that kind of feedback, so thank you for raising that.
Thank you. We have a question. Oh, we've got all kinds of questions coming in toward the end. So one here, and then, so you first, and then you, and then did you have a question as well? No. Okay.
So my name is Paul Shears, and I'm with the West Bay Road and District Volunteer Fire Department. Also represent Straight Area Mutual Aid that has 28 fire department members. Departments, I should say. I want to go back to ambulance response times. I believe EMC has a requirement in rural areas to meet a certain criteria for a response time. I could be mistaken, but based on the number of calls in the past year with a number of the fire departments in Straight Area Mutual Aid, it's become very clear to us they're not meeting their standards that have been set by the government. Reasons are twofold, obviously. There's not enough paramedics manning ambulances, we get that. Straight Richmond Hospital being closed is another big issue for us. That means the ambulances that we have stationed in Arishat, St. Peter's, Port Hawkesbury are either gone to Antigonish or they're gone to Sydney. This is creating huge wait times as MFR departments are dispatched out on medical calls, trying to deal with patients and explain to them the system and the reason for their wait. And I can allude to Blair's statement earlier, because we were on a medical call that evening when that accident occurred in Petit de Gras, and the ambulance that was coming to our medical call was turned around and rerouted to Petit de Gras. And we had to wait another 40 minutes for another ambulance. That being the case, those ambulances that were dispatched that night came from Antigonish. We had none in our area. Also the fact that when this happens, they are rerouting ambulances within the whole area. We've had a number of calls now where we've waited for an ambulance to come from Marguerite, Badek, Inverness. There's been medical calls out in Lordways and St. Peter's where ambulances have come from that distance as well. So I guess my question is, how does the government make EMC accountable to meet these targets? There's no issues with the volunteer fire service responding to medical calls. Let's make that clear. Every volunteer fire department that's out there that's responding to medical calls do so for the public they serve. Okay, so I want to be perfectly clear on that. We also do not get paid, we're volunteers. In order to become an MFR, the volunteer fire department has to cough up over $450 for a member to take the MFR course. EMC is paid for what they do. I don't quite get the fact that EMC should not be covering off the fees required for volunteers to become MFRs. After all, we're stepping up and holding the fort until paramedics arrive. That's a pretty big cost burden to volunteer fire departments, and people have to realize that. So I was talking to Jeff earlier because we had a short session outside there where we discussed a few things. The government's plan with the CCAs was excellent, okay, covering their training costs, excellent. And we were talking about maybe the same thing could happen to paramedics. Okay, why not the same thing happen to nurses? That's thinking out of the box, and maybe that's something that the government needs to actually look at. So, just in summing up, I don't even know what the question was now, but...
Well, your question was, how do we make EMC accountable? And your suggestions were that we look at doing something for nurses and paramedics similar to CCAs. So, I think that's what you were saying.
Yeah, I think so.
And the cost of MFR training.
Which I kind of like.
Yeah. Under review. Do you want to take that one to start?
Thank you, Paul. I haven't been an MLA very long, but I've learned a lot from those two chaps over there, I have to say. I've met with them a few times with my colleagues, and I'm grateful. Helps me understand our system better every time we meet. And so we're really grateful for the work that you do in your community and your dedication, because I know you give hours and hours and hours. And so I really do want to acknowledge you and your colleagues for all the work that you do. So we've met on a couple of occasions, and I know that perhaps, Jeff, there may be some things that you want to talk about in terms of what the work that we're doing. And I know that I think is it February that we're going to come and meet with you and Straight Area Mutual Aid to talk about the role of the MFR and to see how we can better support you in terms of your delivery of service and the way that you respond. So I think there's a lot more to say, but maybe, Jeff, there's some things you want to talk about that we've on the accountability side.
So as I mentioned earlier, I function as the regulator, the executive director for emergency health services, and EMC is our partner in service delivery. we certainly have some challenges. There are things that are out of EMC's hands at the moment. So one of the challenges we have when we take patients to hospitals and we get wrapped up at hospitals for longer than the standard of 20 or 30 minutes to get the patient into the emergency department, those impact what EMC's scope is. And so that impacts our response times across the board. It's not something they can control, but what we can control are, as I mentioned earlier, are the patients that we do take to those emergency departments with some of these novel programs that we're going to put in place. Now, Paul, you know I believe this, but I'll say it for everybody's benefit. We really appreciate the work that the medical first responders do across all of our communities in the province. And I think our hallway session tonight, we had my colleague and friend here, Kevin from the union. First thing he said, he's still an active paramedic. Nothing makes him happier when he arrives on scene and he sees a fire truck and the guys are there and the team's there ready to help out. So we value what you do. But much like much of our system, we have to modernize it a bit. And we really have to look at what we're asking you to do. And so that is a review that's happening now. So we've well undertaken it. And it began after the meeting we had with you folks. And I went on to meet with the Fire Service Association of Nova Scotia to have a better understanding of the challenges that the fire services have and the way that they support the EHS programs. So much like what I had said earlier, status quo is just not an option for anything, so everything is on the table for us to look at. My job and my team's job is to hold EMC accountable for the operating of the service. We've added a few resources to help us do that. We've got a brand new director of regulation and policy. We need to have good, solid policies to make sure that our system functions the way that it should. But like any rebuild, it's going to take some time. So we will continue to do the things we're doing to try to increase the capacity, take the strain off of our MFR partners. And we do recognize that these are volunteers, heart and soulers in their community, and we do have a lot of respect for what they do. But I do want anybody that's in here as an MFR to know that we do hear you, and we are looking at all kinds of options to try to make the changes in place that better support all of our communities.
We're going to ask you for your patience, Paul. But that we keep the dialogue open. How would that be? And you know how to get us if you need us. Like, we want to be good partners to you. Yep. I know you know. I rue the day these two fellas introduced. No, I'm just joking.
So I know we still had a couple questions left, but we're getting really close to the end of time. So I think what I'm going to ask for those of you that still have questions left, if you could please write them on your cards with your email or phone number so that someone can follow up with you. So any that has questions left, that would be great. I want to thank everyone for taking their time, and I'd like to actually call on your MLA for Richmond, Trevor Boudreau, who's going to say a couple words before we close up.
Well, thank you, and thank you for everybody for attending. But you know, last year this senior health team traveled the province and visited with healthcare workers and listened. We've heard that. We all know that. And the second time around, they're coming around and listening to communities. And I would say that's the first and second time that a health leadership team has traveled the province. Maybe I'm wrong, but I think that's the first time in history and the second time in history. So I'd really like to extend our appreciation both as MLAs but as communities that you really do care, and you want to hear what people have to say, and you want to understand so that we can make a difference. And it's been said here tonight, I'm a healthcare worker. My wife, Karen, has showed up, so you actually might get to meet Sarah, who you were talking about earlier. But you know, we have felt this for a long time, and there's 5 MLAs in our caucus that are all healthcare workers, and I would tell you we all ran for very similar purposes. We very value our healthcare system. We've seen it in crisis. We've known it's been in crisis, and we want to make a difference. And so I would say we have probably the most qualified health minister in this country. And I'm not saying that, but we know what we have, and I'm very appreciative to the time that they put in and that she puts in, and certainly how she dialogues with me. So I really do appreciate that. I would like to take the time to extend a thank you to the staff that's here. So we have staff from the Nova Scotia Health and from the Department of Health and Wellness. And like we said, and it's been said here, they used to work in silos, but now they're all here together. And I would really like to thank the staff for coming out and traveling across the province and putting that time in. And I certainly want to thank everybody here. These are challenging times, and you're asking very good questions, and people have a right and a reason to be worried and concerned. But I want you to know that you have a team that really does care, and they really want to put the effort in. And I can tell you that I'm very impressed, and I am grateful for what they do. But thank you for all coming, and I think I'll close by just saying, you know, keep the dialogue going. So you have MLAs here, 3 of your local MLAs that you can reach out to. And certainly, we want to be there for you. So thank you, and again, enjoy the weekend, and happy holidays, Merry Christmas, and all of that coming. So thank you.